Okay, I think we're live, so give me a second to get this shared into the group. There we go. All right, if you're hopping on here, drop us a note, let us know where you're watching from, say hi. I'm just getting this shared into a couple spots before we get started. All right, I see there's a few of you on, so please go ahead, drop a comment, let us know where you're watching from, just say hi. And we'll get going here in just one more minute. Okay. Okay, so we are officially live. Welcome, everyone. I am Amy Zelmer from Faces of TBI, and I am here today with Dr. Perry Maynard from Integrated Brain Centers in Denver, Colorado. Excuse me. And today we're going to be talking about chronic pain after brain injury. And so I've actually seen this topic come up a lot in the TBI tribe recently, just people questioning, like, is it normal to hurt everywhere after a brain injury? Or, like, especially like for me, I had a lot of physical stuff on top of my brain injury, but some people don't, right? So it can be surprising when they have other pain. So I'm excited to dive into this topic today, and I'll try and keep an eye on the Facebook group or on the Facebook feed. So if you have any questions as we go ahead and drop them in the comments, and I'll try to monitor that. But Perry, where would you like to start? Kind of a big topic, but
it is a big
where would
topic.
you like to?
I think a good place to start with is kind of a little bit about what pain is, and I think this education around pain is something that has been lacking and missing for a while, and I think becomes really important when it comes to chronic pain. So I think us understanding what even pain is, and then I think even after that is how do we classify pain? Because in a second, we'll talk about the better we can classify a pain generator or where the pain is coming from, the better we can understand what therapy is ideal, right? Is a body up therapy ideal, right? Working on someone's neck, or is a brain down working on someone's brain the ideal to treat someone's pain? So if we think about pain in simple standpoint, pain is a signal, right? Could be from, let's take my arm, right? So I have different nerve fibers in my arm, and specifically when we're talking about pain, I have what are called like C nerve fibers, and I have different nerve fibers that detect different sensations. But some of these nerve fibers detect things that have to do with pain, right? And those are inflammatory molecules. They can be mechanical compression of a nerve, and this will come into when we talk about how we classify. But ultimately, pain is a threat. Pain is a threat that something is not right. That could be the bone is popping out of the skin in my arm, or my brain perceives as if I have an injury that is equivalent to that, right? And that's where pain becomes tricky, is that the intensity of the pain we feel doesn't always match to how bad the accident is, you know? And this will kind of come to set the stage when we look at individuals who are set up statistically for more prevalence of chronic pain. These are the same individuals who are set up for things like chronic dizziness. And these are individuals who maybe tend to be a little bit anxious to begin with. That kind of the way their brain is wired sets them up for a little bit more of a threat response. So to keep it simple, pain is a signal that something is not right in the body, right? And so we have to alert our brain, and we have to move away from that insulting thing, right? If I'm holding my hand on the burner on my stove, I should know that I need to move my hand away. So we talk about pain as a bad thing, but if we weren't able to feel pain, we probably wouldn't still be alive, right? Pain is a very important evolutionary trait to keep us safe from environmental things. The problem is when it gets out of control, or to say it differently, whatever that threat that was there is now gone. So let's say I did, burn my hand, and it's been 6 months later and everything's healed in my hand. Why do I still have pain? Why do I still perceive as if there is a threat there? So if we go into classifying pain, and a lot of this, what I'm going to kind of state, comes from a work of an Annie O'Connor, who is a PT in the kind of pain science world. And she's written a few textbooks on chronic pain and on pain classification. So anytime we see someone with pain, we want to try to figure out, let's once again, let's use the hand as an example. So I have hand pain. We need to figure out, is there something still wrong with my hand? Is there something wrong with the nerve coming from my hand into my spinal cord? Is there a problem in my spinal cord, or is there a problem in my brain and that I'm perceiving things that aren't there? So if we look at classifications, one of the first classifications is going to be what's called nociceptive, inflammatory, and ischemia. What that means, nociception is a pain signal, right? So it is a word that is describing a painful stimulus. So we know, once again, one of the things that early, if I have inflammation in my hand, so once again, let's say, I fall and I hurt my hand. We know that there's initial inflammation to try to heal my hand, okay? And that inflammation will irritate nerve fibers in my hand that will signal pain. So right off the bat, we need to think with an individual, okay, is there still an inflammatory reaction occurring where they're feeling the pain? Yes or no, okay? The second is nociceptive ischemic. So we know that, let's say, once again, I hurt my hand and I start to get swelling. We know that nerve fibers are very sensitive to any sort of swelling. So when we look at a nerve and the anatomy of a nerve, so we have different layers of a nerve, and in between those layers, we have blood vessels that run to innervate that nerve. And any little compression of that nerve can slow blood flow to that nerve. And so I could have swelling or a compression injury that could be creating pain, but pain due to ischemia. So I could have maybe an elbow injury that's creating pain in my hand because the nerve that comes, from my neck down around my elbow into my hand, maybe it's being compressed from an elbow injury, but it's referring to my hand. And I need to figure out, is it because of an ischemic injury, right? And this is really important because of how we go to treat it. Because if there is an inflammatory thing, that's where maybe doing things from an inflammation standpoint could be helpful. If there is ischemia, then I need to find where the nerve might be compressed so I can decompress it and bring relief, okay? If we move upstream, the next thing we look at, and this is kind of similar, is what's called peripheral neurogenic pain. And I'd say I see this quite commonly post head injuries, right? And especially a lot of times post whiplash. So when we're looking at peripheral neurogenic pain, peripheral means it is in the periphery, so it's outside the spinal cord. So I have my peripheral nervous system, which are all the nerves outside my spinal cord, and everything in my spinal cord up to my brain is categorized as my central nervous system. So peripheral neurogenic pain means that the pain is coming from a peripheral nerve. And like I said, this is very common in whiplash injuries, right? I have a ton of nerves that innervate the back of my scalp, the top of my head, the side of my face, in my jaw. And so very commonly with injuries to the head or the neck, we see that there can be mechanical issues that then cause what's called peripheral neurogenic pain. And so this kind of builds off the line where that nerve has now been irritated and is hypersensitive. And the problem with nerve fibers is that if we think about our eyes, if I shine a light in my eye, the more I stimulate that, the more blind I become, right? So the more I stimulate photoreceptors, the more they start to shut down. The problem with pain fibers is the more you stimulate them, the more irritated they become, right? And we've probably experienced this if you've had a headache and you go to brush your hair. I have long hair, so I experience this problem as well. And your scalp is really sensitive, right? So this light touch that should normally not be painful becomes painful, right? And that's what's called kind of like an analgesic response or hyperalgesia, where a non-trivial stimulus has now become painful. that's giving you a window into those nerves along that distribution are very hypersensitive. Okay. And like I said, I see this very commonly in post-traumatic headaches, whiplash, things like that. A lot of neck pain and headaches are peripheral neurogenic pain, right? And we can, maybe if we have time, chat about some of the ways that we treat these different things, but it's important because the way we treat that is going to be different than these next categories that we talk about. The last few categories we're going to talk about are going to be more falling into the central sensitization, right? And we may be saying, well, what is central sensitization? This is now where areas in the brain that interpret pain have become overactive or hyper responsive. So that means that the nerves in my body are just fine. The tissue is just fine. There's no ischemia, there's no inflammation. The nerve isn't being irritated, but the areas in my brain that interpret pain are just not working how they should be, right? And this is where we start getting into chronic pain or central pain, or what sometimes people call like affective pain syndromes. And I'll stop here, see if you have any kind of questions, because then we can dive into a little bit more of what are the brain circuits associated with central pain and how those are very much associated with anxiety networks, depression networks. There's a lot of interesting data on how socioeconomic status, race, all of these things predispose individuals for less optimal pain outcomes, which is really fascinating.
Mm-hmm. Yeah. I've just had a few comments. Someone said they get overheated easily. Similar but different, right? And then my scalp sends me zaps and feels like it's bruised. And I experienced that when I fell. I literally landed like right here on my skull. And I remember asking my mom to look because it literally felt bruised.
Yeah.
And I'm like, can you look? Like, is there a bruise? And I mean, like, Perry, it was almost a year before I could brush my hair. I had to like hold my hair and brush because I couldn't touch that area. It was so incredibly sore. So I think to some extent it probably was bruised. But then just that, like, I couldn't even touch it. It even hurt to like lay on it in bed, right? But then talking about the neck and whiplash, and I think one of the big problems in our traditional healthcare system is like you go to your GP and they're not really trained in all this, right? Like they're just very broadly trained in medicine and they don't know what to do with you. You know, you might get referred to like maybe orthopedic or something, but then they don't understand it either. Like that's not their thing. Like it's so frustrating to get bumped around, and we're like, especially with headaches. So many headaches can be resolved with like neck stuff, neck therapies. But these people struggle for years with headaches because nobody knows what to do with them. So that's why I really love that we're talking about this today.
Well, and I think you nailed it in that the way we view pain still is just it's not accurate anymore. We are still so focused on this, what some might call like a pathoanatomical model. And you see this a lot of time in orthopedics is you get an MRI and someone's got a bulge disc and it says, there's your pain. And we know from research that that's not totally true, and that plenty of people have asymptomatic or don't have back pain, but have disc bulges. So that's where medicine is always very focused on like, well, where does it hurt? Well, it hurts right here. So there must be a problem right here. And we forget that, once again, pain is a signal that something is not wrong, and it doesn't always mean that it's there, right? We have referred pain. So another really interesting thing is that within our spinal cord, when information comes in, it sometimes goes up and down a few levels before it synapses to go to the brain, right? This is one of the big reasons why maybe a heart attack manifests as jaw or arm pain, is because the nerve fibers come and they all get kind of interwoven together. So that's what can create referral pain. So sometimes just because I have pain in my arm doesn't mean it's coming from my arm. And that's really the job of the clinician, is to listen to the person and take a good history, but to really trace back and understand where along that path it's involved, because just because you have pain in your forearm doesn't mean it's your forearm, you know?
Mhm.
And I think that's the problem in the traditional medical world, is that we're still so focused on where you feel pain, there must be a problem. And then the other piece too is that we still treat pain from those first models I told you about, the inflammatory nociceptive, the ischemic nociceptive. We still pretend that every case of pain, there must be still something mechanically wrong in the wrist. There must still be something in your spine that is creating this pain. And it's not until recently we're starting to realize that there could be something wrong with the circuitry right in the brain. It's no different than like a computer, right? If a computer is not working, the question is like, is it plugged in? Is there a problem with the computer processor? Is there a problem with the electrical company giving you electricity to make it work? All these different things. But for some reason with pain, we become so hyper focused on where you feel it, and then treating it with either pain medications, anti-inflammatories over the counter, and we don't realize that things like cognitive behavioral therapy, or maybe how someone's relationships with a loved one, or how a death, a divorce, how socioeconomic status could be playing into why they may not be getting better.
Yeah. Yeah. As you're talking, it just made me think. So my ex-husband was a chiropractor, and he specialized in carpal tunnel.
Hmm.
And back in the day, like this is like 15 years ago, like everybody seemed to be getting carpal tunnel, which I don't hear about it as much anymore, but I
Yeah.
digress. But people were being told they needed to have carpal tunnel surgery, which
Mhm.
is like an awful surgery. And your carpal tunnel is like right through here.
Mhm.
It was all they needed was forearm massage. Their forearms were so tight, from
Mhm.
using your computer.
Mhm.
And he would massage and work on their forearms, and they were healed. Like their carpal tunnel went away.
Instead
And
of
that,
going through and just cutting,
oh,
you know,
right? Instead of this like very intrusive surgery.
yeah.
And so like it just shows how like your pain might be here,
Mhm.
but it's actually like this. Or I get a lot of shoulder right here, it'll just feel burny,
Mhm.
and it's coming from my upper neck. When I know what that is now. Back in the day I didn't. I thought it was my shoulder.
Mhm.
So that referred pain, and like you said, doctors tend to look at where you tell them it hurts.
Mhm.
Yeah.
Yeah, and this is where we get into, I think once we have ruled out that there's nothing wrong, in the body, once again, that's where I think traditional healthcare has failed quite a bit. And
Yeah.
starting to get back on board, because what's really interesting is one of the things that can sometimes be the best thing for individuals with pain is education on what pain is, right? And what their belief about what their pain means. This is where a term called catastrophizing that you see a lot of times
Mm,
in individuals with chronic pain is someone misinterpreting or having misbelief about what the pain is they're experiencing, right? And Annie O'Connor talks about this in her work, is talking about like yellow flags and red flags, right? Yellow flags being like warnings, hold on, stop. There's something going on in their belief about their condition that is part of the reason they're not getting better, right? And this is maybe an individual who stopped working because of their pain, or says, well, I can never go back to work until my pain is 100% gone. There's no
mm,
way I can live with this pain, right? These little things where, this pain is the end of my life, where you're seeing that they now centrally are interpreting this pain as a massive threat. And the problem with that is that that goes to your certain parts of your brain, one area specifically called your insular cortex, which is all about kind of like unconscious awareness of your body, right? So kind of where people talk about like gut feeling coming from. And you're constantly getting updated information about what's going on in your body. And that sits next to our amygdala, which once again is that threat detection part of our brain. And if that center is constantly oscillating back and forth, And every time they feel a little pain, they think, oh my God, this is the end of the world, I'm gonna die. That limbic brain starts to wind up even more so, and they just kind of feed off each other, right? And so this is where we really have to look at individuals and see how do they perceive their pain, what is the belief, but then also we have to look at coping strategies. So we also know that individuals who have just poor coping strategies in general in life. So once again, this comes back to maybe individuals who are predisposed to anxiety, depression, or tend to be more pessimistic individuals. You start to look to see that there's already issues in some of those limbic emotional areas. So now that when you add in pain, they're going to have a very hard time interpreting it.
So I want to stop for a moment because
Mhm.
I think this is a really important distinction
Mhm.
for caregivers listening.
Mhm.
Um, and like how that interpretation of pain, because I feel like people are often not believed how much pain they're in.
Totally.
And like I'm particularly thinking people who are told like they have fibromyalgia.
Yep.
So let's talk to that for a minute.
Yeah.
Particularly for like
Mhm.
caregivers listening
Mhm.
who are like, oh, he thinks he's in pain again, like
Yeah. No, that's a great point. And this is and it's hard, right? It's a great way because some of this, and I've had this plenty of times where depending on how you describe it and explain it, it very much can come off as like you're just
yes.
writing me off like everyone else. Which I'm not. And it's sometimes hard to it's hard
Like it's
to
actually the brain injury talking.
it's actually the brain. It's actually issues.
Yes.
So specifically when we look at pain, we have different what are called mode networks. So most talked about in like chronic pain is the default mode network and the executive mode network. So these are just networks of different areas within the brain. Okay. You have your executive mode network, which has a whole circuitry that has a lot of prefrontal cortex and executive areas of the brain, right? And then you have your default mode network that is a little bit more activated when one is at rest and when one is in a meditative state. And what we see in chronic pain is that there becomes issues in the way these brain circuits work and the way they oscillate. So a lot of times a brain injury itself can affect the areas of the brain that allow you to properly interpret pain. I'd say more often than not, individuals with brain injuries fall into the last category, which is more of a motor or autonomic pain syndrome, which is where there becomes issues in body mass. So what you can see sometimes is that there becomes, and this was made popularized by Mosley, I can't remember the other guy, two Australians, I think. I don't know if they're PTs or pain scientists, but Mosley, they wrote a lot of early books discussing pain and how pain affects the mapping of a body part, right? And so that the more pain I have, the less I move something, the more the brain says, don't move that because that's a threat. The representation of that body part starts to go away. And so then
Mhm.
my ability to send feel good chemical, all these different things become disrupted, right? And so that's where I'd say a lot of times brain injuries, these individuals are like, I can't feel my left arm, or I don't feel like my left arm is part of me, right? You have these weird dissociative syndromes or sensations, which of course those are going to set you up for a pain phenomenon because you just don't even know that limb exists. And so your ability to maybe control it from a motor standpoint is uncoordinated. So then maybe your ability to interpret sensory information from it is not ideal either. So that's a very common thing that you see with brain injuries is that there becomes a mapping issue and their
Mhm.
ability to understand the painful limb becomes skewed so their brain can't regulate it.
And I just want to take a quick minute for anyone that doesn't know what brain mapping means.
Mhm.
It's your brain knows where every single part of your body is. It knows where this fingertip is. It knows where your nose tip is. And when you have a brain injury and your body mapping can get off, it doesn't always know this fingertip is here,
Yeah.
right? And I lost my train of thought.
No, you're totally right. And I think
Yeah.
I,
And so that can also affect, I know what I was going to say. It can also affect like your proprioception,
yep,
your balance, your depth perception. That's might be why you're walking into things.
yep,
And I think what my point is like, it's all so interconnected. And if you can get that brain mapping back on track,
yep.
it's going to help with the proprioception, but it's also going to help with the pain.
Yeah, it's going to help with your brain being able to come down and modulate, right? Because we always have painful stimulus coming in, but sometimes we're not gating it appropriately because these top-down descending systems are not working to gate pain. So think about it as like, right, we shouldn't feel the shirt on our backs, right? Throughout the
Right.
day, we shouldn't really pay attention. That noise should be gated and the brain should be like, that's trivial. But a lot of times what you see with brain injuries is that everything becomes hypersensitive. Their shirt, touch, they don't like to be touched. They don't like the feeling of bed sheets on their body. So you're looking where the brain is not gating all of this information that's coming in 24/7. And that can be
Yeah.
another reason behind pain. And so this is where you start to see where it's so much more complex than a pill that just
Yes.
shuts down your entire brain, which is what happens a lot of times is and there's a time and a place for medication, but I have a patient right now, and she comes in for, rehab, and it's hard because the pain medication she's on is anti-seizure medication. So when she comes in, her brain literally is just not working.
Mhm.
Like she literally, for that time period, looks like she's got dementia while she's on the medication because everything is just depressed. And no, she's not in pain, but then memories, all these different
Yeah.
things get affected.
The
So
trade-off.
it's a trade-off, and there's so many things that can be done conservatively up until that point. Going back to this is where things like mirror therapy or graded motor imagery, which once again was popularized by Mosley and colleagues on remapping body parts. So what we'll do a lot of times is we'll use a mirror and they'll look at the good limb and we'll do things where we'll touch the good limb, different sensory input to the good limb. We'll give them pictures of right and left arms and they have to distinguish right versus left, how to use it. So you're starting to remap how they represent that limb. And a lot of times you can find that maybe touch the arm was very painful and then you can get it to go away in like 30 minutes, and then you start to notice they have better coloring in their hand. Their arm's not going purple because that's what you see in like what's called CRIPS or complex regional pain syndrome is now the way they influence blood flow to that limb becomes distorted. So maybe the painful limb's purple. And you're like, why is my left arm black and blue and super painful? Well, if you don't know where your arm is, how well are you going to regulate blood flow to it? How well are you going to regulate pain? And then all of that poor blood flow is going to lead to damage to nerves, which is going to further exacerbate the pain, right? And this is why it's so important to know when you might do mirror therapy with somebody versus maybe you're going to do laser directly on their ankle because there's a problem right there at their ankle. And there's a time and place for all of that.
So I do have a couple comments. So Jason, he survived a fall 430 feet down a mountain. But he said he basically broke everything in his body. He says he channels his pain fairly well, but cold weather is rough. I'm the opposite. I like cold weather. My stuff doesn't hurt as bad, but I know other people are the other way around when it's cold. Or for me, it's weather change. Like when we have, I think it's a drop in barometric pressure, my neck will get really tight. So do you want to kind of address those two things?
Yeah, definitely. I mean, when you look at pressure changes can be a variety of things in that we know pressure changes influence inner ear function. And we know that inner ear function sits. So what's actually interesting is there's actually a migraine device and it was actually created by David George. You might know him. He's a neuro who did FNOR with Stuart Fife, but he's got a migraine device that's really cool that I think is going through research right now. But it actually uses that concept where it goes in the ear and it fluctuates pressure of the membrane and actually can be helpful in modulating pain. So we know that the inner ear or the eardrum and some of the sensors in the ear are very much associated with a part of our brain called our trigeminal system, which is our pain detecting system of our face and our neck. And so that's one reason where sometimes temperature shifts or pressure changes can throw off pain, because it throws off right, kind of your brain's, the way that pain circuit is working a little bit. When you look at temperature, it is interesting because you do see differing things. It was actually interesting. I don't know, have you watched there's the new show Limitless with Chris Hemsworth and Peter Tia on Disney. Either way, there's an episode on cold therapy, and they reference a woman who had, I want to say, fibromyalgia or really bad nerve pain, and she found that swimming in cold water helped to manage it significantly. So she actually became a cold water diver, like a free diver. And it's interesting to me because, like you said, there's some individuals it can be very irritating, and I don't fully know the answer. My thought is that
I'm curious, now that you're saying this, I'm curious if he has any metal in his body.
Yeah, I think sometimes when cold is really beneficial, it's harnessing more central nervous system areas. So we know that cold therapy improves dopamine, it improves epinephrine, norepinephrine, it improves production of opioid type compounds. But at the same note, if nerves are very hypersensitive, like if there's a lot of peripheral neurogenic pain, that cold can sometimes just be way too much of a stimulus for them. So I think that, and I don't know if I necessarily have any science to back up my kind of hypothesis, but what would make more sense is that if the cold is really irritative, there's probably more of still a peripheral neurogenic pain where the nerve endings are being irritated, versus a central pain could have benefit because the cold exposure is improving production of feel-good neurochemicals, and so an individual feels better, if that makes sense. That would be my thought of why one might respond well to it and one might respond negative to it.
Yeah, like I said, I prefer cold.
Yeah.
Hot weather just makes everything just ugh.
Yeah.
But now don't get me wrong, because now we're in winter here. So I
Yeah,
have my
right.
days I'd rather be in Florida.
Exactly. Everything
So
still is always better on the beach.
yeah, everything's better on the beach. Exactly. Well, Perry, this has been a great conversation. I just want to take a moment, see if anyone else has any comments in here. We had quite a few people watching. Delray Beach,
Awesome.
Florida,
Hey,
Canada,
they heard us.
Texas, Phoenix, another nice warm place.
Yeah.
So
Well, hopefully whoever is in Texas is okay. I know I was talking to my mom this morning who lives in Dallas, and they had tornado warnings everywhere. So they got some pretty gnarly storms going on
it's
right now
weird
down there.
weather across the US right now, I think,
Yeah.
which I mean, like those storm fronts can mess with my neck and headaches. I know that.
Yeah.
So Perry, this has been great conversation. Do you have any final thoughts on chronic pain?
Yeah,
I mean,
I think the big thing is if you're going to a practitioner and they're not having the type of conversations that we've had today, then I think you need to find another one. And I think the important thing to realize is that, and once again, this is more is that the intensity of the pain doesn't always match the threat, and that there is hope, right? There, sometimes
right.
pain can feel so debilitating that nothing can help. And sometimes being able to get to an individual who can help to shift the outlook on that pain or help to understand what is generating it can be wildly impactful. I would suggest for any clinicians for sure, and maybe people look into the work of Annie O'Connor. Like I said, she's a PT out of Chicago who has done a ton of good work on pain management and chronic pain. So I think definitely every clinician should be aware of Annie O'Connor's work. And then also for people too, looking into some of that work as well, I think can be helpful to start educating yourself of like, what is pain? What's going on? And how can I maybe figure out where my pain source is coming from, so I can figure out, is it cognitive behavioral therapy that might be helpful? Or maybe it is PT, maybe it is chiropractic, but really finding someone that can guide you along that that continue on.
Awesome. Sorry, there was a car alarm going off. I hope you couldn't hear that.
Whoa.
Well, this has been a great conversation. If you're watching the replay, drop a comment. We'll try and check those as well. As I said, Dr. Maynard is at Integrated Brain Centers in Denver, Colorado. They do week-long intensive. So if you're not in the Denver area and you're traveling, you can go in for a week-long intensive with Dr. Perry. And I just can't say enough. He's helped me with a lot of my dizzy issues. And fortunately, I haven't had a lot of pain other than neck pain. But I think we've gotten that under control. So thank you so much for being here today. Thanks everyone for watching. And again, if you're watching the replay, go ahead, drop a comment. We love hearing from you guys. So thanks everyone. Thanks, Dr. Perry.
Thank you so much.